Welcome back. First of all, the weekend. However, you need to be invested on your studies also. But do please take care of your health, of your mental health, of your study life balance also. Very important. Coming to today's session, it is on the next commonly used crystalloid, which is your ringer lactate. I wouldn't say next commonly used, but it is also a commonly used crystalloid. We want to know what is the impact on the intravascular volume, impact on the acid-base balance, and whether there is any impact on interstitial edema, and what is the advantage. Whenever you talk about an advantage, there will be an invariable disadvantage also. So you should know both sides of the coin. So this is your ringer lactate. Now, why this confusion? Somebody will call lactate, somebody will call Hartmann, somebody will call ringer lactate. It goes on and on. If you know how exactly this terminology evolved and what exactly happened to the changes that happened in the composition and why, you'll have a clearer picture. Nobody will be able to mess up with your concepts. So coming to Ringer, he is a British physician. As early as 1880, to normal saline, he added calcium and potassium because his objective was to raise the cardiac contractility in frogs in their experiments. What did Hartmann do? In 1930, he added lactate and sodium and chloride was reduced. These two components, they were reduced, not taken off, they were reduced. Why? Because he wanted to counter acidosis. This chloride ion is very acidotic. And he introduced lactate to counteract the acidotic nature of chloride. And they also reduced the chloride concentration and the sodium concentration. Now, by introducing lactate, they took care of chloride. But how was lactate metabolized? It gets metabolized to bicarbonate by the liver. And if your liver is diseased, difficult for them to clear the lactate. So again, by now, slowly the Hartmann solution started changing to ringer lactate, and now it is known as ringer lactate. So you must understand both these are the same. Only thing is, over a period of time, it got changed into ringer lactate itself. Composition is the same. Now, when they realized lactate can't be metabolized easy by the liver, they started introducing ringer acetate. So that was added. Now, acetate, you need the muscle only to clear. And any failed system, any failed physiology, most important, the first one will be the brain, the heart, the lungs, the kidneys, the liver. The skin and the muscle and the bones, they are sort of down in the hierarchy. They still keep functioning. They don't fail as such. So it is taken up by the muscle, which still manages to function and gets it cleared out. So when it is in the intravascular space, it does not cause much acidosis, but it does give the volume that you need to rev up the pressure in the intravascular space, and it does not need a very healthy liver to metabolize. It can get rid of by the muscle. So these are the advantages. Now have a look. We want to compare normal saline with the rest of the ringers. So your normal saline, you know, has a very high sodium and chloride content and a very low pH, very high osmolality when compared to plasma. Now let's look at Ringer's injection. The Ringer who had it potassium and calcium for the heart contractility, he slowly brought down the chloride levels. Not much, but he at least managed to bring down the sodium levels. But they introduced potassium and calcium, and pH was slightly more. However, osmolality remained the same. But what happened next? Instead of they introduced lactate and they reduced the sodium and chloride concentration. So when they introduced lactate, the first thing is it reflected on the pH. It's no more acidotic. And because they brought down the sodium and the chloride, osmolality also was brought down. In fact, it is hypoosmolar to the plasma now. What did acetate do? People felt lactate, you need a healthy liver, so let's introduce acetate. See, they have introduced acetate. And of course, the sodium and chloride levels are still low, but you start getting a better pH. Not much difference, but definitely a better pH than this pH. And osmolality is down. What are the advantages over isotonic saline? As I told you, it is the acid-base balance. Not much in the volume replacement, but in the acid-base balance. What is the disadvantage? As I told you, there is calcium. It will bind to the citrated anticoagulant, install RBCs and promote clot formation. So when you want to dilute your packed RBCs so that they can be pushed through your system into the veins, you will not use ringer lactate, but you will use normal saline that time. You see the advantage of saline over ringer lactate in this particular scenario. That is why there are advantages and disadvantages, and they depend on the scenario they are being used. However, clot formation does not occur if your amount of ringer lactate that you're using is only half of the blood product. Now coming to lactate, as I told you, lactate levels are a standard marker to diagnose, monitor and prognosticate for shock and sepsis. It is routinely used in the intensive care units where you're treating patients with shock and sepsis. Not only to diagnose, but also to monitor and prognosticate. So the lactate content in ringer lactate solution, it made a concern. Are they spuriously, is it there an hyperlactinemia? You don't know whether patients really got lactate levels high because of shock, or this is the lactate which is reflected in the IV fluids. Now, if you have a healthy liver, you need ringer lactate. 1 liter over 1 hour will not raise the lactate levels. But in critically ill patients and in large volume infusions, this could be a problem. So, and one more thing, when you take blood sample from intravenous catheters that are already being used to give lactate infusion, you should avoid that situation. Now, so you will be taking from the other infusion sites where lactate was not being infused. This is the practical points. So coming back to our queries, this is the first slide. What is the impact on intravascular volume when using ringer lactate? The impact, it is 25% will stay in the compartment, just like any other crystalloid. There is no change in that particular aspect of ringer lactate. Impact on acid-base balance, yes, significant impact will be there. It will not push to acidosis. Interstitial edema, the sodium is far less. So it will not go and park in the interstitial edema and cause a extravasation of fluid from the cell into the interstitial compartment. So there is no significant edema. What is the disadvantage? Lactate may not be cleared by the ailing liver, or large infusions of lactate even with the normal liver may have a issue. So to avoid all that, acetate has been added because you need only muscle to sort it out. So this is a very short presentation. Now these are very much clinical scenarios, but nothing to demonstrate with the clinical image. So I've only remained in the physiology part, but they are very much what is happening inside a patient's body. Now please do read it up. I've given very basic information so that when you get multiple choice question with options, your concepts are clear. You'll be able to get the right option. Don't mug. When you mug, all these problems happen. So you must know how the concept of ringer lactate came, why it came, and then you must also know the advantages of ringer lactate over other crystalloid, which is your normal saline. and also the disadvantage and how the disadvantage is being sorted out by using acetate. So please keep these evolutions in mind. When you keep evolutions, your learning will be almost in a nice trajectory. You will not get confused here and there. So thank you so much, and as usual I will ask you to subscribe, like and share, and also I want to remind you there is a Telegram channel.